Okay, we'll go ahead and start. And this next talk, I think we flipped the schedule around a little bit, but this talk is going to be on infectious processes involving the paranasal sinuses. Let me just. Excellent. So for the next 30 minutes, we're going to talk about infectious processes involving the paranasal sinuses. Let me set my timer here because there we go. So what I'm going to do over the next 30 minutes is talk about some of the more common diseases that you'll see regarding inflammatory process involving the paranasal sinuses. And again, it's impossible for me to go through everything. What I will do is I'll try to go hit the highlights and give you a little better sense of the most common things that you'll see in your practice. So the first thing that I want to talk about is this thing of a cyst versus polyps. And oftentimes, I'm always asked when someone looks at a CT or an MR, is it a cyst or a polyp? And the bottom line is we're really not going to be able to tell. Now, there are pathologically cysts in the sinuses. There's something called a mucus retention cyst, which is essentially obstruction of a mucinous gland. And there's also a serous retention cyst, which is an accumulation of serous fluid within the mucosal lining. So there are two different types of cysts. And these are, you can make the argument that these are cysts, and they look like a cyst to me. It looks like this is a well-defined area of low attenuation within the left maxillary sinus. And when we perform a T2 weighted imaging, we can see mucosal thickening involving the alveolar recess. So I think it's pretty easy to say this is a cyst, and that's fine. It's good. Now, what's a polyp? A polyp is a distinctly different entity, and a polyp is its infiltration of the eosinophils in polymorphous leukocytes, in the submucosal lining of the mucosal epithelium. And these are typically seen in patients that have allergies, some type of infection, cystic fibrosis, etc. That's typically the patients that get polyps. Now, what does a polyp look like? So this is a contrast-enhanced T1 weighted image, and this is probably one of the best examples I've seen of a polyp. So this is an MR scan, and when we give contrast on the MR scan, what we see here is enhancement of the mucosal lining. Everybody see that enhancement in the mucosal lining? And below that enhancement, we see a lot of this non-enhancing redundant areas of low T1 signal. And at surgery, this is the polyp that's been resected, and we can see it's a bunch of junk. It's a bunch of soft tissue. But again, with a leap of faith, you can see how this disease can be located below this enhancing mucosa. So remember, polyps are actually infiltration of leukocytes below the level of the submucosa. So fundamentally, there is a difference between a cyst and a polyp. But from a practical standpoint, what do we say on imaging? So I've had people sort of argue with me, is this a cyst or is it a polyp? And I'll say, well, I don't know. Well, why isn't it a cyst? Because it has a rounded margin. And it very well may be. But the way that I was trained, again, in the last century was anytime that I see mucosal thickening involving a sinus, and unless it has a clear fluid level, I will just go ahead and call this polypoid mucosal thickening and describe the extent of it. So I'll say that this is polypoid mucosal thickening involving the alveolar recess and involving the zygomatic recess of the right maxillary sinus. So that's how we describe things. Now, occasionally, we can make a specific diagnosis. So this is a patient that has some type of polypoid thickening that's extending through the secondary ostium of the maxillary sinus, extends into the nasal cavity and out through the posterior choana. So anybody want to tell me what this diagnosis is? What do you call this? What? A sinus polyp. What specifically if it goes to the sinus and into goes to the choana. There you go, anterochoanal polyp. So this is a true anterochoanal polyp, and it derives its name because it's involving the maxillary antrum and is extending through the posterior aspect of the choana. So that's an anterochoanal polyp. Now let's talk about this disease entity called sinusitis. So first of all, sinusitis is not a radiological diagnosis. It is a clinical diagnosis. So we'll look at a CT scan, and many people say it's sinusitis. It's not sinusitis. Our job is to define the extent of the disease. And how do I know this? Because when I was a radiology resident, my second year, I knew I wanted to go do head and neck radiology. So the second time I rotated on the neurosurgery rotation, you had a lot of patients that had intracranial hemorrhages, that were intubated, that had a bunch of disease in the sinuses. So me, with my interest, I would ignore the brain hemorrhage, but I would say the patient had disease in the ethmoid sinuses, and I would say they had ethmoid sinusitis. So about 2 weeks into the rotation, my division head comes up to me and says, "Hey, how's it going?" I said, "Oh, it's great." He said, "Well, you may not want to continue to say ethmoid sinusitis." And I said, "Why?" He said, "Well, right now, the ENT surgeons are getting a little bit annoyed because neurosurgery is now consulting them on all these patients that you're saying have ethmoid sinusitis." So at that point, I learned that sinusitis is not a radiological diagnosis, it's a clinical diagnosis. So when we look at the normal drainage pattern of the maxillary sinus, realize that here is the maxillary sinus, and the way that you get out of the maxillary sinus is that you extend through this area here, which is the primary ostium of the maxillary sinus, and then the disease continues to extend along the maxillary sinus into this space, which is called the ethmoidal infundibulum. The little bone right here on the below the ethmoidal infundibulum is the uncinate process. And then once you get to the top of the ethmoidal infundibulum, this is the hiatus semilunaris. And then the drainage from the hiatus semilunaris ends up coming into the middle meatus. And then this area right here is that middle turbinate. So all of this is the osteomeatal unit. So the components of the osteomeatal unit are the primary ostium of the maxillary sinus, the ethmoidal infundibulum, the uncinate process, the hiatus semilunaris, and the middle meatus. So what the surgeons do when they perform the typical functional endoscopic sinus surgery is that they end up removing the uncinate process, they end up removing the medial wall of the maxillary sinus, and essentially what they're doing is that they're opening up the space, that disease that can then flow into this enlarged middle meatus. So that is the osteomeatal unit, and that drainage pattern is the basis of functional endoscopic sinus surgery. So what acute sinusitis is when there is an obstruction involving the primary ostium of the maxillary sinus, and this disease cannot normally drain out, essentially you end up developing a obstructed fluid stew, a bruise there. So because there's no oxygenation, eventually what happens is that this becomes a very good area for acute bacteria to develop and grow and expand, and then you end up having acute bacterial sinusitis. So this is an example of an air fluid level involving the left maxillary sinus. Again, what I would do is I would say there's mucosal thickening, and then I would say there's an air fluid level that's consistent with the diagnosis of acute sinusitis. I won't say it's acute sinusitis based on imaging, but I'll say it's consistent with a clinical diagnosis of acute sinusitis, and on the MR scan, again, we can see the air fluid level here. Now, this is an example of a patient that has disease involving the right frontal sinus. We always have to be a little cautious when we see opacification of the right frontal sinus, especially in patients that are symptomatic, because with the leap of faith, again, maybe there's a little bit more disease here, it's hard to say. And I want to make the point here that even though this patient has disease involving the frontal sinus, notice how the posterior wall of the right frontal sinus is intact. And always remember their emissary veins, because if patients are symptomatic, realize that disease involving the frontal sinus can extend intracranially. And this is an example of a patient that has a scalp abscess here. They also have an epidural abscess here. And then when we look at the sagittal images, we can see the coronal reconstructions, and we can also look at the MR. And when we can look at MR, we can see this patient has a meningitis as well too. So does anybody know what the name of this disease entity is? You got it right. That's Pott's puffy tumor. This is described by cervical Potts, Percival Potts many years ago. Now, if This disease is not treated. It can go on to having a very severe meningitis. So this is an example of a patient that has a meningitis. There's diffuse enhancement. And if you look real closely and have a sharp eye, you can start seeing a separation between the enhancing dura medially and the inner table of the calvarium laterally. And when we look at the T2 weighted images here on your right-hand side, what we see here is an empyema. So this is an example of a subdural empyema that was associated with acute sinusitis. And another example here, this was on diffusion weighted imaging. This is the diffusion study, and we can see high signal here along the paramedian aspect of the falx. And when we look at the ADC maps, we can see there's actually low signal on the ADC maps as well. So here's a diagnosis here. This is another potential complication of a patient that has acute sinusitis. I'm going to go back to my regular arrow here, I think. Let's see here. Oh. Hold on for 1 second there. Pointer options. This one, there we go. Whoa, don't look. Did you see it? It clicked on me there. So the point that I wanted to make here is, where is the abnormality? Is it anterior or is it more posterior? So what we see here on this non-contrast sagittal T1 weighted image is that we see increased signal involving the posterior aspect of the superior sagittal sinus, and this is a case of superior sagittal sinus thrombosis. This is an example here of an MRV demonstrating lack of flow involving the posterior aspect of the dural venous sinuses. And we know that if you have occlusion of the dural venous sinus, we can end up having an intracranial hemorrhage. And because this doesn't really have a configuration with an arterial distribution, this is the typical parafalcine hemorrhages that we see with the dural sinus thrombosis due to and resulting in this venous hemorrhage. Now, you can either perform MRV or you can perform CTV to look for superior sagittal sinus thrombosis. And in a way, it's debatable. I think if you ask 100 radiologists if they like CT or MR better, 50 will say CT, 50 will say MR. Some people like MR better because you can perform diffusion imaging to look for infarcts. I personally like CTV better. And the reason I like CTV better because it's quicker and it's less expensive. And you can also see this appearance here. Now, the appropriate term for this is the empty delta sign. It's not the delta sign, it's empty delta sign. Why do I know that? Because I trained with the person that named the term empty delta sign, right? So what ends up happening is that this is the superior sagittal sinus, and we can see there's clot. There's no enhancement in the clot. But the superior sagittal sinus, the dura around it, actually has a potential space. So when you have clot in the superior sagittal sinus, the blood is redirected along the leaves of the dura that create the superior sagittal sinus. So empty delta means that instead of having diffuse enhancement in the center of the superior sagittal sinus, there is no enhancement, hence it's empty, and there still is this residual delta formed by the redistribution of blood in the leaves of the dura of the superior sagittal sinus. Now, what exactly is a mucocele? So, a mucocele is a complete opacification of a sinus that's expanded. Now, I'm going to contrast that definition to what we see here. So, we talked about acute sinusitis, and really we would look for an air fluid level. But this is an example of chronic sinus disease. Now, how do we know it's chronic disease? What do we look for? Anybody? Thickening of the bone, exactly right. When we look at this, we can see there's thickening here along the posterior lateral aspect of the maxillary sinus compared to this on the right side. So that way, that tells us that we're dealing with chronic disease, and this is sinus disease that's extending through the primary ostium into the maxillary sinus. So this was a coronal image, and this was the axial images telling us that this disease process is not acute, but it's been around for some time. And as I mentioned before, mucocele is chronic disease that is defined by complete opacification of a sinus and expansion of the sinus. Now, anytime that you have chronic disease in a sinus, it can eventually become desiccated and it can start concentrating proteins. So when we talk about acute sinus disease or when we talk about cysts and polyps, these are mostly fluid. But if you have a chronic disease that's involving a mucocele, realize that this mucocele can eventually become dehydrated and it can start to concentrate protein. So this is actually a mucocele. Now when you look at this, you're going to say this actually looks like a tumor involving the frontal sinus. And mucoceles sometimes can mimic neoplasms. So in this particular case, we see this abnormality involving the roof of the left orbit. It's associated with bone erosion. Now, if you see something like this, you have to go through your differential diagnosis, but think in the back of your mind, could this be a mucocele? And if you have any questions at all, do a non-contrast T1 weighted image. Because in this particular case, this was due to a mucocele, and the high signal here indicates that this was due to proteinaceous material. So it looks like a tumor here on CT, but when you perform the MR, you can see the T1 shortening, and this tells you that you're dealing with a mucocele. These are all examples of mucoceles, and they make some interesting points about mucoceles. Here is complete opacification of the frontal sinus. We can see that there's expansion of the sinus, and here we can see the bones eroded. And again, this is confirmed here on the coronal images. In fact, with the leap of faith, you can see all these little bubbles here and all the balloons of the mucocele. So this is another example of a mucocele, a non-contrast T1 weighted image with fat suppression. We can see the high signal in the ethmoid sinuses. Why is it high signal? Because it contains protein. So that gives us our T1 shortening. And look at the T2 signal here. The T2 signal is sort of intermediate. This, on the other hand, is a mucocele that was caused by a patient that had previous sinonasal surgery, and the sphenoethmoidal recess was occluded, and therefore the sinus can drain. So this is a post-surgical mucocele involving the sphenoid sinus. But what I want to point out here is look at the signal in the mucocele on the T2. In this case, the signal is very low. So understand that the MR appearance of mucoceles can be very variable. On T1, they're typically high signal, but on T2, they can vary. And this is an example of a post-traumatic mucocele. There is a story behind this. This was given to me by my friend Bill Nemzek. This was a man who was sleeping, but his wife caught him in bed with another woman. And she came at him with a pickaxe, you know, a pick, and started beating him up with a pickaxe. And you can see that there's a lot of encephalomalacia here involving the frontal lobes, and this is a post-traumatic mucocele. And so, unfortunately, this is the frontal lobe, and he never remembered anything from this. The other thing that we have to be remember is that when you have mucoceles and they occur in the sphenoid sinus, it's a very, very sensitive area, because when we look at the sphenoid sinus, realize all the sensitive structures around it. So in this case, this was an old case that demonstrates a mucocele involving the sphenoid sinus. There's erosion of the posterior wall. And on the coronal images, this just demonstrated a very nice but a very subtle case of an empyema involving the planum sphenoidale. And I show this case because this was a case I came upon when I was at University of Michigan, and it still scares me in the sense that this was a case that was seen in the middle of the night. It was a child, and it was read out as normal. And I think in general it probably could be normal, but in children you should not have dilatation of the temporal horns like this. They were a little dilated, and again, I looked at it the next day. I wasn't quite sure, but they called it normal, and unfortunately 6 hours later the child died. He went into septic shock. And when you go back and look at it, when you go back and look at this case, on the bone algorithms, notice there's complete opacification here of the sphenoid sinus, and it probably was here before, but the only way that we could put this together was that it's possible this child, as in the case I showed before, ended up having a mucocele involving the sphenoid sinus, was symptomatic, and at this point they probably should have gotten a contrast-enhanced CT at this time, because my sense is that there probably was a meningitis, and this is what caused the dilatation of the temporal horns, and unfortunately the child expired later. So the take-home message is that if you do have children that have isolated sinus disease in the sphenoid sinus, this is really an unusual place. And if the patients do have fever, if they do have some type of symptoms, have a very high suspicion that there could be something else going on, and don't hesitate to try to do follow-up imaging. And this is just an example of disease that can extend into the cavernous sinus in a patient with acute sinusitis. This is an example of, notice this right cavernous sinus here in the carotid artery. It's very, very narrowed. And in this case, on the axial and gradient echo image, there's complete loss of signal involving the carotid artery. So this, in this case, is an example of extension into the cavernous sinus with narrowing of the internal carotid artery. And in this case, there's complete involvement and complete occlusion of the right internal carotid artery, and these are all complications. We talked about those cavernous sinus thrombosis earlier, and these are just two more examples of phlegmon extending into the cavernous sinus. So the last thing that I'm going to talk about in the remaining time is fungal sinusitis. Now, the reason why I think that this is important is that if you ask an internal medicine physician and you say fungal sinusitis, they're automatically going to assume that you're referring to the acute invasive fungal sinusitis, and we'll show examples of this. But really, from an imaging standpoint, we have the ability to better characterize and classify the different types of fungal sinusitis. So the classification that I like to use was published about 20 years ago in the New England Journal of Medicine by DeShazo, and he separated out fungal sinusitis into 5 different types. So there's an allergic type, there's a mycetoma, there's granulomatous, there's allergic fungal sinusitis, and then the last one is the acute invasive fungal sinusitis. And since that time, there have been modifications to this. There was an article in the 2009 in Laryngoscope, and I have modified this classification to include this as well. But in my remaining time, what I want to do is go over and talk to you about this, because here, especially in Egypt, you're going to see all of these. In fact, you have this disease, which is the granulomatous disease. And my friend in the front row here, I read his paper back in 1999 where he described various types of granulomatous disease involving the head and neck. So here, especially in the arid climate here, you will be seeing all of these different types of fungal sinusitis. I think it's important that you have some understanding of them. So people are taking pictures. You got it? Got it? Okay. I didn't want to flip the slide in the middle of your picture. You can take a picture of me too if you want to. That's okay. So the first type of fungal sinusitis that we see is, at least in the United States, is the most common type. And this is what we refer to as hay fever. The fancy term for this is saprophytic. So saprophytic basically means it's sort of latched onto your nose, and you may have some type of sinusitis, if you will, would change in seasons. So in the United States, we have 4 different seasons. And in the springtime, there's a lot of pollen. And when there's pollen in the air, a lot of people have hay fever. So this is, if you will, a saprophytic type of fungal sinusitis, which is non-invasive. So it's aspergillus. So realize this is a type of aspergillus. But the imaging findings are non-specific. So you look at a CT or an MR and you see some sinus disease in a patient that's sneezing in spring, it's probably hay fever. But there's nothing on the imaging study that tells us that it's specifically due to hay fever. This is the second type. And again, I want to point out that, again, this is aspergillus. This is what's referred to as a mycetoma. Now, the Laryngoscope paper says don't call it a mycetoma because that's confusing. Call it a fungus ball. So if you want to call this a fungus ball, that's completely fine. And so when we look at an axial CT image, what we look for is a chronically diseased sinus, and we literally look for this this high area, this rounded high area of increased attenuation that is floating in a chronically diseased sinus. So this is what we will refer to as, you can call it a mycetoma. I've always called it a mycetoma, but some papers will say just refer to as a fungus ball. It's completely appropriate to do so. But again, realize that this is aspergillus as well, but it's non-invasive, especially in a normal host. Now, this disease I don't see very much. So if anyone has a case of this, I'd love to see it. This is what has been referred to as granulomatous rhinosinusitis. And this granulomatous rhinosinusitis is more prevalent in India, it's prevalent in Sudan, it's prevalent in Egypt, and some other countries with arid climates. And we really don't see this in the United States. We see something similar to it, and we see something that's been referred to as chronic invasive fungal rhinosinusitis. So what this is you take the Aspergillus, and this Aspergillus does have some type of invasive properties, but it's not really going to kill you. It's a little bit invasive. And this is sometimes known as the Aspergillomas. So the point here is that this was a patient that had some type of immunocompromise. And this is a coronal T1 weighted image, and this is the optic nerve, and we see this mass that's located here, just below the optic nerve. And when we give contrast, we can see this densely enhancing, and there's a little bit of enhancement here along the meninges. Everybody see that? Now, what fungus tends to do is fungus tends to get desiccated, so it's chronic, but it also tends to concentrate a variety of heavy metals. And some of those metals, calcium is not necessarily metal, but it can concentrate calcium, but it can concentrate manganese. So a lot of these fungus tend to concentrate these heavy metals. And so when you perform T2 weighted imaging, in this case what we see is a mass here that is low T2 signal. In fact, you can look at this right here, and that's probably a part of the optic nerve here on the right-hand side, and there is the mass here. And then on the sagittal images, a sagittal T2, notice how there's low signal as well too. So this was biopsy, and this came back to be quote-unquote an Aspergilloma. So I guess in a way to look at it, I can argue that chronic invasive is sort of analogous to granulomatous fungal sinusitis. And this is what the paper in laryngoscope said a few years ago. Both of these are Aspergillus. This is Aspergillus flavus, and this is Aspergillus fumigatus. So this has less hyphae, this has more hyphae, but the point is from a natural progression standpoint, it seems they are fairly similar. This is an Ant Mini. This is allergic fungal sinusitis. Now, the key thing to making the diagnosis here, do you see this here? Sort of? Maybe? Well, if you haven't seen it, maybe you will see it. This is an Ant Mini. The key thing to making this diagnosis is that we see all of this disease, it's involving multiple sinuses, and it's eroding the bone. But the key thing here is this is a non-contrast CT. It's non-contrast. If it was contrast, it's a totally different ballgame. But in this non-contrast CT, we see all of this disease involving multiple sinuses. In fact, there's intracranial extension. On this one, there's axial images here extending actually into the cavernous sinus. And this patient on the right was transferred into, when I was at University of North Carolina years ago, because they thought they had a rhabdomyosarcoma. And I remember we looked at this and said, gosh, this is allergic fungal sinusitis, because no contrast was given. So allergic fungal sinusitis is, again, another type of Aspergillus. It's sort of invasive, but it's not nearly as invasive as what I'm going to show in the next slide. It can involve multiple sinusitis, and this has been described by the surgeons as being quote-unquote allergic mucin. There's a lot of eosinophils there, and the surgeons claim when they perform their endoscopy, it's like removing toothpaste or tooth butter or something, or peanut butter, that's what they say. And this is just an example here of the allergic fungal sinusitis, and it looks like this is normal, right? Right? Think it's normal? Same patient. Yeah. And the reason all that signal loss is there is because of the heavy metals in the protein. So a couple points here. You may not see it on MR. And also on MR, I'm very reluctant to go ahead and call the sinuses and comment on the aeration because of all the dephasing artifact. And the last thing that we'll talk about is the one that you're most familiar with. This is acute invasive fungal sinusitis. It's sometimes called fulminant or rhinocerebral. This is the one that's seen in post-transplant patients and also patients that are diabetic. Now, this is an example of a patient that has this disease, and the point of showing this slide is that this patient has invasive fungal sinusitis, but I cannot tell the difference. So in the early stages, you just cannot tell the difference. It can look like anything. But This patient has it. Now, this patient has a chronically diseased right maxillary sinus, but someone has to tell me, how do I know that this patient is at very high risk to have invasive fungal sinusitis? This is probably the most important slide of this whole talk. So it's not necessarily bone erosion, but if you draw a line down the middle and you compare this side to this side, the bone's intact, but there is disease outside the sinus. So if you look real closely, can I convince you that there's disease here? You see the disease here? Look at the nice fat here involving the left pterygomaxillary fossa. See that? And then look anteriorly, anterior to the sinus. See the canine fossa here? See this disease? And compared to the opposite side, there's no disease. That's the earliest findings of invasive fungal sinusitis. That's where you can make a difference. Because if you continue, and this is another example here, another example of invasive fungal sinusitis. See how it's involving the pterygopalatine fossa? See the normal fat on the opposite side? That's the earliest findings. Because, another example here, lots of increased attenuation here compared to the opposite side. See the subtle abnormality here on the right side compared to the left. That sinus is well aerated. But this patient was diabetic, heavily immunocompromised, and all of a sudden had very, very high fevers. And this was invasive fungal sinusitis. Because if you don't catch it at this early phase, what ends up happening is it goes on to erode the sinuses. And here we can have frank erosion of the alveolar recess of the maxillary sinus. Another example here, this is the disease here. Everybody see this? There's where you want to catch it. You only see what you look for, you only diagnose what you know. You see that? If you don't catch it, it can go on to erode the maxillary sinus, and then it could extend superiorly into the pterygopalatine fossa. And remember, 3, 4, and 6 run through the pterygopalatine fossa, and you can have a frozen eye, so the patients can lose their eye. Another example here, if it's untreated, it can go on to erode the anterior wall of the maxillary sinus, and then once it gets into this area, it extends into the muscles. So now we have a myositis that's due to the invasive fungal sinusitis. In this case, it's not only is involving the muscles here, but it's also involving the orbits as well too. If it continues to extend on, it can grow into the cavernous sinus, and eventually it can involve a cerebritis involving the medial aspect of the left temporal lobe. And in this case, we can actually see the patient's developed abscess involving the medial aspect of the temporal lobe. This is one case that still haunts me. This was a patient that had invasive fungal sinusitis. And I remember talking with the neurosurgeon in this case. We can see there's something wrong here involving the sinus. It actually grew into the nasal cavity through the cribriform plate. And when we look at the T2 weighted images, there's a lot of cerebritis here involving that frontal lobe. At this point, I was saying, why don't you go and resect it? He didn't want to resect it. And unfortunately, the decision, I don't know if it made a difference or not, but this is that same patient. The same patient died 2 months later of invasive mucormycosis. And the last thing is that invasive fungal sinusitis has the term that's angiophilic. Angiophilic means it loves vessels. And invasive fungal sinusitis can extend back into the cavernous sinus. If it loves the vessels, it can grow on the vessels and occlude it. And unfortunately, this patient ended up having a left MCA infarct that was due to the invasive fungal sinusitis extending into the cavernous sinus and eventually occluding the cavernous sinus. So what I want to end with is this take-home message: a patient at high risk, make sure you look at the sinus, but please look around the sinuses. Look anterior and posterior to the sinuses, because these are the early findings of invasive fungal sinusitis. Take a picture of that one, all right? All right, that's the take-home message. So in summary, what I've tried to do is we talked about cysts versus polyps. We talked about sinusitis, talked about mucoceles, fungal sinusitis, and then complications. So thank you very much for your attention.